Welcome to the Cup of Nurses podcast.
What's up, guys? Welcome to the Cup of Nurses podcast with your hosts, Matt Solarczyk and Peter Findera. Peter, what are we going to talk about today?
What's up, guys? Today we're going to talk about some myths for new grad nurses and also offer some tips for your first year out of nursing school.
Awesome. Let's start with the first one. What is the first myth, Peter?
A lot of people think that where you start is where you're going to end up, which we could both attest that's pretty false.
I agree. What is your experience with that one? Did you end up? Are you still where you started, or have you switched?
I am where I started, but initially I wanted to go into pediatrics, like peds ICU, come to nursing school. That was my interest. I like kids. I like taking care of kids. I like dealing with families. Unfortunately, there was no jobs available for me in the peds ICU, so I decided to do cardiac step down and cardiac ICU, which I thought it would be okay for me, and I really enjoy it. I enjoy the stuff that I do. I had fun on a unit, and I didn't think much of it. I thought I might be like there temporarily until an opening comes available for the peds ICU, and then I jump ship. But what about you? You switched around a little bit.
Yeah, so it looks like you've grown into yours. And for me, I started as a med-surg nurse, and that was completely different to where I am now, the ICU. So working med-surg, it was different. I developed like a routine after a little bit. It was 6 patients. I never dove down into like the care of like my patient, understand what's going on, like, minute to minute, the vital signs, the lab values, constant draws, and things like that to really figure out like, how critical is my patient, what has to change, what has to be done so you could get back to better and, step down and hopefully leave the hospital. So definitely what I initially thought of med-surg, I grew out of it, and I'm tackling a new experience, which is in the ICU, and I'm enjoying it.
Yeah.
So
But I mean, a lot of people don't want to change careers or jobs. They're usually scared. Hey, what if I end up somewhere worse than I am? And some people just get too comfortable.
Right.
You get comfortable, you get stuck in a routine, and you just keep doing stuff over and over and over and over, which some people like comfort. But if you want to learn and grow, change is definitely the way to do it. Even if you like where you're at, like your unit, just venture out a little bit. You can always come back if you don't like where you went. But hey, try some new stuff out. It's your first year out of nursing school. People don't think much of it. And plus, you got that first year out of the way already. So you kind of know a little bit, like you kind of, the general scope, what's going on in the hospital and how to do things. But the specialties, just try something out. You do cardiac, do medical. You do adults, do peds. Try it out a little bit.
Exactly. And one thing is the fear of changing your job. Like, don't be afraid. Like, people have to realize that growth exponentially happens on the other side of comfort, which is fear. It's stepping outside your comfort zone, trying new things. And let's face it, like, it's better to fail than to never try, right? There's a quote like that. So go out there, do your best. If you don't know what's going on, you're going to get oriented. Someone will help you out. You ask questions, and you'll grow, and you'll grow as a person, and confidence, everything. It's amazing. Like,
exactly.
Don't be afraid to try different things,
Right.
Whether it's a specialty, different hospital. So,
It's fun. It's fun trying new things. Another myth, people think that learning stops once you graduate. Matt, you just finished your CR, and congratulations.
Thank you.
How's it feel?
Feels pretty good. Same stuff, different day if you think about it. But the continuing education is different for me. So instead of doing like 20 CEs to maintain my license every 2 years, I think I have to do like over 100 hours every 3 years to get recertified. So not only does it help me keep up to date with like my evidence base and all that, I'm going to understand more. I could bring topics to the table where we are now. And so definitely, just because you're done with your textbooks, you pass your NCLEX, it doesn't stop. It only continues from here.
Exactly. Yeah, I mean, you don't stop learning. I mean, there's always new medications coming out. There's always new medication you're giving. Even if you're a specialized unit, you're going to give some, a lot of psych meds, I feel like, even though you're not really doing psych patients, but I feel like a lot of people have their depressions or whatever. But learning the procedures, policies, that's just a whole different task of its own. Especially when things change. You get a new Meplex dressing. You got in-service on that thing.
Yeah.
New Craig bed or something. You got in-service on that. You keep learning, and not even those little things. You still learn more about the human body. You learn more about the critical thinking aspect of nursing. When to give certain meds, when to not give certain meds. And just people want to go back to school as well.
Right.
So it's an option.
And then you also learn as a judgment, for example,
Right.
when to hold medications. Like some patients, the metoprolol, for example, lowers you could become sinus Brady. If it's like 59, 60, for some patients, you might hold it because you know how low it drops them. For
Right.
some, you could still give the same dose and they'll be good throughout the night. You're not going to have any issues.
Right.
So not only are you learning in that aspect, you're learning from a clinical aspect and how to judge situations better.
Exactly.
So
yeah, just bouncing off that, even though a patient might have like a blood pressure stalks in the 100s, but a lot of times we give metoprolol just for like a little bit of rate control.
Right.
They get like a 12.5 milligram just because, they get a little tacky during the day or during the night, or they go into AFib for a little bit, but then they
Right.
throw themselves back. You just want a little bit of that rate control.
And then, bouncing off that as well, I hate when some people hold it and then there's that rebound effect of metoprolol and then the patient is super tacky.
Yeah.
And this nurse had to call at night and get Dig instead because she was a little hypotensive. So it's just different situations.
Yeah. But you just learn as you go. We're all growing together. We're all nurses. A lot of people also think that you can be on your own when you're a nurse or coming out of nursing school. Do you feel like you're alone, lonely? Do you feel lonely at work?
Definitely not. But I did when I started. So this is the myth that I debunked myself as well through experience, is that floater sync mentality. I got off orientation and everybody's like, you'll be fine. And I almost felt like, wow, that's it. I'm going to be on my own. I better do this or I'm not going to make it or I'm going to get
Right.
fired. And just putting dumb thoughts to myself, just overthinking the situation, and it's not true. There's definitely nurses, every unit is different, but they're so helpful. And if you don't know anything, like you ask questions and they help you out like you are not on your own. So.
Exactly. Yeah, I feel like, we become nurses, we have that nurture aspect.
Right.
Even those guys, I always want to help people. I always look for whoever's struggling, help them out. You can see the look on their faces if they're struggling. And yeah, I came out of orientation thinking I should know everything.
Right.
I shouldn't ask questions. I was scared to ask questions because I'm like, hey, I should already know this by now. Why do I know this? So instead of asking questions, I would look stuff up and I would take more time than asking a question, which is kind of counterintuitive if you think about it.
Exactly.
A lot of critical thinking is, especially in ICU and stuff, is more on the spot. Like, hey, we got to do this now and take care of this now. But yeah, you won't feel alone if someone's going south. There's alarms. You're not gonna be the only one in your room during a code, or if someone's respiratory distress, you're gonna hear the alarm going off. So everyone's gonna run in there to help you out, and it's just good to bounce off ideas off everybody. You might have a different view or different perspective compared to the older senior nurse on your unit that's been doing it for 42 years, like your one friend over there.
Yeah.
And you give them some insight, and they give you some insight, and it's just like a happy place.
Care gets delivered better, right?
Exactly.
So I do agree with that one. What about the myth that nurses run doctors' errands? How do you feel about that?
Not anymore. When I initially got hired, I felt like a lot of stuff did get pushed on us. Like we talked about the physician consults.
Right.
A lot of that wasn't going on, and sometimes you might feel like MDs don't respect you as much because you're a nurse and they think you might not know as much as they do. But
right.
But we're hands on with the patient. We're in direct contact. We're in the front lines. But yeah,
sometimes when you have to be direct with them and let them know what's going on. And speaking of consults in the ICU, it should be physician to physician. Sometimes that does not happen. The doctor gets lazy and he just leaves it for you. And there are nurses that send a friendly page and, hey, don't forget about your consult. Don't forget to call them. So it's just becoming consistent with that and helping the doctors do their job sometimes, because yes, you do get pushed down, and especially from a patient to patient, you're taking care of patients, you get loaded some things that you got to take care of for them. Then from the higher up, you got the doctors pushing down on you, and you're like this middleman that's taking care of everything. And that's why we're awesome superheroes. Right. But at the same time, hey, we can't be loaded like, doctor, do your job, or
exactly.
Hey, do this consult. So you have to be direct and don't be afraid. They're human.
Right.
They're human.
As nurses, we do have our own scope of practice, and also you don't want to get more work thrown on you than you initially have coming in, because that's just workload sucks sometimes.
Exactly.
Yeah. So Matt, you got any tips for us? Us new grads out here?
Yeah, we should probably help them out. So one of them is the power of asking questions. Don't forget about that. Just like Peter said, he got maybe a little too confident, didn't want to make it look like he doesn't know anything, and yeah, you're Googling your own questions.
Right.
Ask questions. collaborative work is always better. Two heads always work better than one.
Right.
And sometimes one scenario that you had is going to be different from the scenario you had with a different patient. So things are always different. You should always ask for like a second pair of eyes on anything. So
right, exactly. Yeah, I mean, ask questions. That's we're gonna try to hammer that into your head because you don't want to push them at the low pressure too quick and then this dude bottoms out real quick instead of having a controlled decrease of the blood pressures. And if you were to ask, hey, how long do I push this for, or how quick can I give this, that easily been avoided. There's no dumb questions. I mean, we're nurses. We got at least associates, but now they're pushing more towards bachelors.
Exactly.
So we do have some experience behind us, and we're all intelligent individuals.
Right.
No such thing as a dumb question. You're gonna know something someone else is gonna know.
Exactly. Don't hesitate. Clarify.
Right.
No such thing as a stupid question. That's the takeaway from that.
Even with physicians, if you're kind of curious on how some kind of illness works, or like the stages of some kind of a disease or stages of heart failure, don't afraid to ask a physician either. I mean, they're there. They know they went to school for that kind of stuff, so they're probably offer more insight and more of like the theory on it compared to nurses would be more of the hands-on and kind of a cause and effect, if you could say.
That is true. Then another tip, I would say self-care. It's not an opinion, or it's not an option, I should say. It's a necessity. Burnout is real, right, Peter?
Yeah, burnout sucks, and when it hits you pretty hard. You burn out at work, you come home, you burn out more. You start sleeping more, you start being lazy, you start doing less. Time management becomes an issue. I mean, you gotta take care of yourself. Especially if you do nights. If you do nights, you gotta be able to adjust. From your night schedule to your day schedule.
Exactly.
You gotta try and be, a day person while you're a night person at work.
Power to all the, or shout out to all the night nurses, and shout out to us for doing that, because it does take a lot. It's a mental toll. You're fighting your own circadian rhythm, and it sucks. Definitely, one thing I do that I prioritize my self-care is by taking little breaks. Even though we're busy, I'll tell the nurse, hey, cover my patients, and I'll go to the break room. If all I have is 5 minutes, I'll do that. Sometimes I have a pair of headphones on, and I'll put like a little peaceful music on, take some deep breathing, like meditate, like soothe myself. And when I open that door out of the break room, I walk in, I feel refreshed. Like there's a difference in the alarms I hear. I'm just more clear and focused.
Yeah. Speaking of self-care, we actually got our massage chair on our unit. So shout out to CSU CVTU 8 East and the management Esther. Got us a massage chair. First time we got it, I had an orientee, so I decided to leave my orientee for 20 minutes and hit the chair for 20 minutes.
Okay.
It's pretty chill. Like caresses you, tickles you a little bit. Place I never knew I had. It squeezes your arms and your legs. Ooh.
That's awesome. How did you feel when you hopped back on the unit?
I felt good.
Difference?
Yeah.
Good.
I felt more calm, more relaxed, and I kind of was like, for sure, let's finish off the next 6 hours.
Right. And we don't prioritize breaks.
No, not at all.
Sometimes it's like, it's not the culture to take breaks. I feel like we have that on nights, and we have to snap out of it. Tell your nurse, cover the patient, your colleague, and go take a break. It's really important. It makes a difference in your day.
Exactly. I think I went the first year of nursing without taking a single break, and then I realized, hey, cafeteria opens at 12:30. It's usually when I go down for a walk. I don't even buy anything. I just go leave the unit for 5-10 minutes, and that helps so much. You refocus your mind. Especially if you had a stressful first 6 hours.
Yeah.
Kind of go down there, recuperate, relax, and tackle the next 6 hours after that.
Yeah.
Mm-hmm.
Next tip I would say is to be assertive. One of those things that I feel like the nurses have to just develop that confidence within them, and be assertive to the patient, to the doctor, whatever the case might be. Just walk the walk. It's almost like, hey, you walk into the room, poker face. Even if you might not know something, don't pretend like you don't know. Say, I'll let you know the question. But it makes a difference with your tone, your body language. Everything resonates with the patient. One time I had a family member that told me, wow, I trust you, and I'm able to go home for my first night out of the 2 because she wasn't comfortable enough with the nurses. And I reassured everything's okay, nothing's going to happen. I told her, go home, rest up, come back, you need it. I noticed how tired she was on her face.
Right.
And she had the trust in me, and I was assertive. I explained what I had to. I was confident, and it plays a different role. It's not only for yourself, it's for the patient,
Exactly.
for the whole holistic thing of the hospital, you know?
Yeah, exactly. I mean, the best advice I could give you in that aspect is do your homework. You know, if you see a pneuma that you see on the MAR, look it up instead of going into the room and just giving it, be like, hey, this is cool.
Yeah.
You can take it now. Because if you don't know it, chances are your patient doesn't know it, you know, and they might ask you a question. Some of these patients are actually intelligent individuals, and they're going to ask about their meds.
Right.
Some of them don't, obviously, but it's okay. But when they do, you don't want to get stumped and look like, you know what you're doing.
Right.
You know?
And on the reverse of that, there was a respiratory tech that, like, I didn't see confidence in her, and I had somebody on life support, which they are intubated, and we have to go downstairs to CT scan. So that being said, I go down with her because it's a 2-person job to take down the CT because she has to manage the vent. And she just wasn't reassuring to me. Like, I didn't see the confidence. It seemed to me like she wasn't sure with what she was doing sometimes. And that bothered me, and that raised my anxiety and stress level when I'm taking the patient down. You know what I mean?
Right.
So confidence is not only within yourself, but if you don't see it within other people, it can affect you as well. So
Right.
it's really important to be assertive in the nursing field, you know?
Yep, present
Because you're
yourself.
dealing with people's lives.
Right. Yeah. So present yourself as an assertive individual, you know, confident, and just do your homework.
Yeah, exactly.
Yeah.
Next tip, learn to admit your mistakes.
Oh yeah, that's definitely a big one. You know, a lot of times starting off, we're gonna make a few mistakes. Like you give a whole pill of metoprolol, 25 milligrams instead of the 12.5 half dose, and blood pressure drops, heart rate goes down. And you don't want to admit that, hey, you gave them too much blood pressure medication, so you're just like, I don't know what's going on, and then here comes the NP or the resident or the physician, and then what's going on? You know, you don't want to say you don't know what's going on, because clearly you messed up. So just man up to it, say you messed up, and fix the problem.
Right.
You know, instead of having people troubleshoot different medications, you know, maybe they're thinking, you know, he's got a stroke or something because he dropped the blood pressure, he's going septic, something's going on, they're going to do blood cultures, all that jazz. Instead of you could just be like, hey, yeah, I gave him too much metoprolol. Oh, okay, cool. Well, just too much metoprolol, and just keep monitoring, see how he does.
Yeah.
You know, worst case scenario, we could push atropine or whatever.
Right. We are human and it happens.
Yeah.
So,
But just admit them.
And it could be with anything less. It could be with like antibiotics, for example. You might have gave less than you're supposed to. So if you have to follow a risk master because it's a med error, whatever the case might be, just go through the process. And next time it won't be as big of a deal.
Right.
Next time you might be more assertive and double check what you're doing, and you won't make that mistake. But it's okay to admit your faults.
Exactly.
Just so it doesn't affect anyone around you, especially the patient. So.
Right. I mean, I would admit that, you know how you crack antibiotics?
Yeah.
You know, there's been times where maybe I forgot to crack it, you know.
Right.
Or I forget to hang the saline lower than the actual antibiotic, and nothing goes in, so you got to give it, you know what I'm talking about?
Yeah.
So when you run as a piggyback, you want to have the saline be under the antibiotic, so it goes to gravity, you know, and it does happen. So just, you know, hey, missed the antibiotic dose. Can I still give it, or do you want me to just skip it and just do the next dose? Little things like that, but, you know, they all affect the patient.
Next tip, task management. So proper note-taking, proper SBAR, the proper way to manage your day so it's easier for you. Because just like when anything, if you have proper systems in place, it makes your day easier, it makes your time easier, especially your shift if you know what you're doing. One thing I like is like my report sheet. I have a special one.
Yeah.
It goes why he came here, the history, little like box for like the time he came to now, what kind of little procedures he had, and then a review of systems.
Right.
And I'll go in order, especially I'm giving a report to you, I'll go neuro, respiratory, cardiac, GI, GU,
Right.
skin, anything like AccuChecks, and I'll go over my lines, my drips,
Yeah.
I'll go into vent settings, I'll go into anything miscellaneous, and it just organizes me for a report. I don't gotta look at the computer as much. And it could be anything like, it could be as simple as making a post-it note, like, hey, don't forget consult in the morning, don't forget to chart my Q2 restraints, little things that are in place that just make your shift easier. Because let's face it, you forget things.
Exactly.
Like you get busy and yeah.
Yeah, I mean, love your report sheets. I love my report sheets. One of my biggest pet peeve is people don't go off the report sheet.
Okay.
And they stagger all over the place. You know, we have, like you said, your report sheet have a systematic, you know,
Right.
from head to toe, body systems, all that. And I hate when people venture out of that. Because we have a unit report sheet.
Okay.
And, you know, it's
See,
ideally,
we don't.
See, we have one, and everyone uses it except for a few nurses, and it just drives me crazy because they're all over the place. They're going from, like, neuro to, like, how much they void to like lung sounds to like they're all over the place. I'm just like, all right, let's try this again. Like give me to it from top to bottom because I don't want to write all over the place. And making no sense. So just hit the points. I mean, I really enjoy report sheets. And there's been many times where I forgot something, but I had it written down on the report sheet.
Yeah.
Which I do like them a lot.
And also like proper SBAR. So know what's going on.
Especially the physicians. They
Exactly.
want their straight business. They don't care how your day went. They don't care what's going on. They just want you to why they're here, what happened, what's the problem, and they're gonna tell you what to do.
Exactly. And even like if you're calling the patient, right? Or I'm sorry, calling a doctor, be specific to the point and don't like beat the bush, you know. So let's just say low urine output, these are the fluids running. Do you want me to give a bolus? Do you want me to do that? Like sometimes you have to ask the physician what you want.
Exactly.
If you're in critical care, you kind of know a little bit.
Right.
Message might be different, or if you don't know, ask them, and it's just the care gets better. Or if they call, you don't gotta go over like this simple stuff because he already read the message, you know. So
yeah, that's really good advice, Yeah. So all right, guys, we hit you with some tips, some myths. Hope you guys enjoyed it. Had a great talk.
Thank you guys. Catch you guys next week.
Deuces.